Good afternoon, everybody. Welcome to this workshop, which is surgical approaches and assessments for Lennox-Gastaut syndrome. For any of you I've never met, I am Scott Perry, also known as the notorious EEG on Twitter. If you wanna pop a follow on that. I am a pediatric epileptologist. I'm also the head of neurosciences at Cook Children's Jane and John Justin Institute for Mind Health. And I also serve on the Medical Science Advisory Board of the Lennox-Gastaut Foundation, and my areas of interest are genetic epilepsy and epilepsy surgery. So I'm going to talk to you about one of my absolute favorite subjects, which is the use of epilepsy surgery in Lennox-Gastaut syndrome. I'm going to try not to move too much because I see you have that camera on me, but it is after lunch, and I don't like to stand still, and I don't want you to fall asleep, so that's why I chose not to stand up there, okay? I have some disclosures just to be clear. I do work with a lot of companies in the epilepsy industry. None of these are much related to surgery itself except the company Cadence, which is developing another surgical therapy that I'm actually going to talk about in this talk. So here are our objectives for today. What I want you all to go home with is I want you to understand the characteristics of people who may be candidates for epilepsy surgery. I want to then kind of frame it in talking about what are the goals of epilepsy surgery. What are your goals for epilepsy surgery? And then talk about, as best I can, the data as it relates to Lennox-Gastaut syndrome and epilepsy surgery. I'm going to walk you through what a typical epilepsy surgery evaluation might include. So you are aware of what you might be getting yourself into if you sign up for something like this. And then the last part, I'm going to talk about some work that I do. So I'm also the president of the Pediatric Epilepsy Research Consortium, which is a national organization of over 75 epilepsy centers and over 500 researchers dedicated to researching epilepsy and answering very tough questions that need lots of people to answer them. And so I run the surgical portion of that as well, so I'm going to go over a lot of the studies that we've done to try to get to better answers on how to use epilepsy surgery best. So I want to just get a feel for who I'm talking to today. So how many people in this room have ever been through an epilepsy surgery evaluation? Okay, now of those people, keep your hands up. So of those who've been through the evaluation, how many of you subsequently went through with epilepsy surgery? So that's pretty much everybody who had the evaluation continued with the surgery, okay? And of those people, how many of you thought it was worthwhile? Okay, that's a pretty good listing of people who thought they got something out of it. Now, how many people have been told by their care team that their loved one with LGS is not a candidate for epilepsy surgery? Okay, some of the people who have been through evaluation have also been told they were not. And then how many people have never had epilepsy surgery discussed as an option for treatment at all? Okay, so at least everyone has had it mentioned. That's good. That's not what we often see, so that's a good thing. Okay, so this is my take-home message right here. Epilepsy surgery is not a last resort. And unfortunately, that's where it gets put so many times. So everyone that has epilepsy, frankly, almost everyone that has epilepsy is a candidate for epilepsy surgery. Some people are just better candidates than others. And so it's just a matter of choosing or understanding who is a good candidate, why they're a good candidate, and that also leans back on what are your expectations, what are you trying to achieve in this. Epilepsy surgery isn't discussed enough. I sent this tweet out years ago before the LGS conference when we were in Dallas, right? And I had just seen a kid in clinic before I went to speak at that one. It was a kid we did a Corpus callosotomy on, and we went into that surgery obviously just trying to reduce seizures, but this kid was seizure-free for the first time in her 14 years of life of every seizure type she'd ever had. It's a completely new kid. And, and then somebody, wants to let me know that, gosh, thanks for mentioning that because I didn't even know this was an option. That's the reason this is an important subject. People need to at least know it's an option to consider. So epilepsy surgery is vastly underutilized in the United States. It's vastly underutilized throughout the world. Fortunately, in the United States, the number of people being considered and treated with epilepsy surgery is increasing, but less than a third of people who are candidates for epilepsy surgery actually ever make it to being evaluated. So that means there's a lot of people who are candidates, and as I said, The people who are candidates for epilepsy surgery continues to grow with all the new ways we have to do it. And so a lot of people are being left without having this discussed as an option. We published a few papers really scoping out all the things that are causing this underutilization, and there's a lot of things. There's misconceptions. That's probably the biggest one. Misconceptions of what epilepsy surgery is used for, who is a candidate for it. Misconceptions by not only caregivers, but their healthcare providers at how dangerous epilepsy surgery is, what the risk of epilepsy surgery is, those kinds of things. And of course, there's a lot of healthcare inequity. It's not an easy thing to do an epilepsy surgery evaluation. It is not a cheap thing to do an epilepsy surgery evaluation, and some people just simply don't get that opportunity because of the inequities that we have in our systems. So, who benefits from epilepsy surgery? In its simplest form, people with drug-resistant epilepsy benefit from being considered or at least talking about epilepsy surgery. Drug-resistant epilepsy is defined as the failure of 2 appropriately chosen and appropriately utilized anti-seizure medications. Failure means you're not seizure-free. It's as simple as that. Like some people get on meds and they're like, oh, we're only having 4 seizures a year, so you're controlled. No, you're not. You're still having 4 seizures a year. That's not controlled. Controlled is 0 seizures per year. So that is still a failed drug. It might be a good drug, might be better than anything else you got, but it still hasn't completely done the job. There are some cases, there are many predictors that predict for us that a person is at high risk for drug-resistant epilepsy. Things like very early onset in the first year of life, having infantile spasms, having very frequent seizures, having an underlying etiology like a brain malformation or brain injury. And those are many of the things that we see in people that have Lennox-Gastaut syndrome, right? So we can recognize early on that these are people who probably are at high risk for intractable epilepsy. So it ought to be in your healthcare team's mind from the beginning that this is somebody we really need to be thinking about surgery, something to discuss as an option. So this is kind of where that definition comes from, right? So why do we say 2 meds? Failing 2 meds is the reason that we do that. Well, the reason is because of data like this. So if you take all people with epilepsy and you put them on their first drug, about 50% of those people will be seizure-free with the first drug they ever try, and they'll go live happily ever after. If they fail drug number 1 and we put them on drug number 2, about 15% of them will become seizure-free with drug number 2 and go live happily ever after. If you fail drug number 2, your likelihood of becoming seizure-free with drug number 3, 4, 5, 6, 7, 8, and 9 gets smaller, 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 and smaller. 4%, 2%, 1%, less, 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 less. Point there is that a lot of people get to the point where they're thinking about epilepsy surgery and they're on drug number 8, 9, and 10, right? Because their healthcare team was like, well, surgery's not going to make you seizure-free. Well, neither was drugs number 3, 4, 5, 6, 7, 8, 9, and 10 either. So, waste of time. You should have at least talked about surgery as an option. It might not have been the best option, but you should have had it. Right? And when you're thinking about surgery, you're thinking about your goals. So like I said, after drug 2, everything is not going to, seizure freedom is not our question anymore. Now it's how much can we reduce the seizures, what is the most beneficial thing we can do with well tolerated, right? Risk benefit. And your benefit may be something different. It might not, maybe it is seizure reduction. Maybe it's seizure reduction and it's a certain type of seizure, right? Maybe your kid has 3 seizure types, but one of them is a tonic-clonic seizure that goes into status all the time, and one of them is a tonic seizure that falls and makes them, break their teeth out. You want those fixed, right? And if medicine's not going to do it, we want to talk about surgery. So maybe it's not seizure freedom. It's just let me get rid of that seizure type. Maybe you want to reduce meds, right? So maybe you're on all these meds and you want to get reduction of seizures so you can be on less meds. Maybe you want to improve quality of life because maybe if they don't have that really long seizure and you don't end up in the emergency room, while it's not seizure freedom, it still improves your quality of life that you don't have to go through that all the time. So that's a conversation you have to have with the healthcare team. Like, this is what my goal is, and so what's the thing that's going to get me to that goal? And so, I say that, you should have everything. Everything should be on the table for you to think about. It's the decision should be another med, another med. It should be another med's an option, and here are all those meds. Diet's an option, here are those diets. Surgery is an option, and surgery can be done all of these ways. Maybe we could do nothing. I mean, those are the options. You have to look at all of those and decide risk-benefit-wise which one makes the most sense for you. So let's talk about some of the data around epilepsy surgery. I'm gonna have data about epilepsy surgery in general, and then I'm gonna try to give you some on LGS. There's not a ton of data on LGS and surgery, so we got a little left to work with. But let's start with this. Epilepsy surgery in general, I'm talking about all epilepsy populations with drug-resistant epilepsy. Epilepsy surgery will end in seizure freedom more frequently than continuing medications. That has been proven in several very good randomized controlled trials. If you went to the talk earlier on drugs, right, we talked about randomized controlled trials and how they work. These are studies where they randomized people with drug-resistant epilepsy to either getting surgery or continuing on to medications. And what you see is that in the first study, 58% of people after surgery were seizure-free, and only 8% that continued medications were seizure-free. In the second trial, 73% were seizure-free versus none of the people who continued medications. These are very particular studies in temporal lobe epilepsy. That's not Lennox-Gastaut syndrome, but the point is that there are studies that show epilepsy surgery can be superior to medications, and they've been done in both adults and in children. This is what you got as far as approval. These are the drugs that are approved for the treatment of Lennox-Gastaut syndrome, okay? And what I want you to focus on is what we report in clinical trials often is the responder rate, which was the 50% reduction compared to placebo. And sometimes we report seizure freedom, and these clinical trials are also very specific often to seizure types. In LGS, it's frequently drop-type seizures that we talk about. Drop seizures are tonic-type seizures, myoclonic seizures, sometimes that result in fall. Atonic seizures, tonic-clonic seizures are all in that category. And so when you look at that, and again, you're looking at things like seizure freedom, as you can see, the rate of seizure freedom is not especially high in any of these trials. There's one Felbitol where 44% of the patients were free of generalized tonic-clonic seizures, so one type of seizure. And in the clobazam study, 25% were seizure-free from drop attacks. But as I said, seizure freedom is not the goal of epilepsy surgery in this case often. We're talking about seizure reduction, so we want to look at that responder rate. So Dr. Sandy Lamb is actually with us here, the author of this paper, and this was a paper that looked at corpus callosotomies. It was a meta-analysis, so they've taken a bunch of studies of corpus callosotomy, put it together. You got 337 patients that had callosotomy, and 68% of the patients had more than a 50% reduction in their seizures 2 years after the procedure. Okay, and I'm gonna keep that in mind. 68% with greater than 50%. We'll compare that back to that medicine slide I showed you just a second ago. They also looked at a few other things. They tried as best they could to look at other domains beyond seizures. A lot of these studies don't include non-seizure outcomes, so it's hard to do that. But importantly, small numbers of people saw declines in non-seizure, whereas 50% showed some improvement in something like quality of life, cognition, et cetera. I think the most important thing that came of this is that last line, is that 90% of the parents were satisfied with the procedure. So regardless of what any of these scales tell me, the fact that 90% were satisfied tells me that something good must have come of it. It was worth it, or at least they didn't regret the decision to do it. So I'm going to take you back, right? 68% of the patients after callosotomy had 50% reduction, and this is what we got to work with here. So none of those drugs reached 68%. We looked before, I compared kind of callosotomy to medications. Callosotomy has also been compared in other studies to things like vagus nerve stimulation and callosotomy in general for certain types, atonic seizures in these studies. Callosotomy was more likely to achieve 50% and 75% of reduction. Same for keto diet. For atonic seizures in particular, they have shown a bigger success for callosotomies versus that. So surgery this is the typo I wanted to correct because it doesn't prevent cognitive function because that would be really bad. We don't want that. It prevents further decline or it may improve cognitive function, okay? But we know, like seizures no good, okay? Like, the more seizures you have, the worse off we are. And the younger you have the seizures, the worse off you're going to be from a developmental standpoint. So the earlier we can recognize this and the sooner we can get the absolute best control we can, the better I think you would do. You know, people always ask me, they're like, well, will reduction of seizures improve your cognition? I've got a teenager, if we reduce seizure, I'm going to improve it. I doubt it's going to make it worse. I mean, more than likely, if we can reduce the seizures, we stand a better chance of getting better. And that's because, there's a lot of things that go into improving cognitive function, like the epilepsy itself, like episodes of status epilepticus, the frequency of seizures, how bad the EEG looks in between, the use of a bunch of seizure medicines, all of those things play into impacting your cognitive and developmental function. And we can only correct some of those, but epilepsy surgery may allow us to reduce seizure numbers. It may allow us to change how the EEG looks in some cases. It may allow us, hopefully, to get on less seizure drugs. So it is something that can alter some of those contributors. These are just some studies that kind of look at evidence for that developmental improvement that I'm talking about. This first one is in infants under the age of 3. That had epilepsy surgery. Again, these are not people with Lennox-Gastaut in particular, but 22% after surgery had greater than 90% reduction in their seizures, and 71% of those people showed subsequent developmental improvements. This other study, which was done a little later in age 3 to 7, again, 66% were seizure-free, and 71% of them showed developmental improvements. The one thing that's key about these developmental improvements is the people that did best were the people who were the longer we wait, the harder it's going to be to fix things. And that's why I encourage people to be aware that failing 2 drugs is when you need to start at least thinking about it. It might not be the time, but you need to start thinking about it, because the sooner we can get the best control, better. Okay, there is some data in LGS. So here's a study of people with LGS who, some of them had abnormal MRIs, so they had focal lesions on their MRIs that we could possibly do surgery. Some people had completely normal MRIs, and they divided those. So the people who had focal abnormalities, they underwent focal surgery. We removed that abnormality. The people who had normal MRIs, some of them were candidates to have a resection and a callosotomy, and some of them were not candidates for surgery in this group's mind, and they continued medications. And so then they kind of compared their outcomes. And so what you can see kind of down at the bottom is from a seizure-free standpoint at 1, 3, and 5 years, the people who were seizure-free vastly outnumber the people on meds that were seizure-free. Okay, so surgery was better. Now, let's be fair about this data. These are particularly selected patients. Some of these people have lesions, so of course they're likely to do better because we can remove the lesion. But even the people who had normal MRIs who went through a resection did well. I'm sure the people who didn't go into surgery didn't look like the people who got a callosotomy. My point here is not that everybody needs to have surgery, it's that everybody needs to be evaluated, because if you have the characteristics of those people who could do well, you should have that option. This study was great because it actually, in what it had available to it, looked at IQ and quality of life. And so the important things to look at here are IQ improved in 67% of the patients after surgery, but only 4% of those who continued on medicine. More importantly, maybe, IQ worsened in 12% of the people that had surgery, but it worsened in 43% of the people who continued to take medicines. Quality of life, same, improved 72% after surgery versus 4%, and quality of life worsened in 7% versus 48%. So these are those kind of things that people worry about when I go to surgery. Am I going to affect their learning or affect quality of life or whatever? Yes, there is a risk. Those things can happen after surgery, but that same risk exists if you continue medications, and maybe even higher. This is just another study that I think really shows us that seizure freedom is not absolutely necessary for cognitive improvement, so we don't have to focus on that. This is 106 children. They underwent corpus callosotomies. They had developmental and epileptic encephalopathies, of which LGS is in that grouping. 22% were seizure-free, but 42% showed improvements in their development. So that just tells me that you don't need to be seizure-free in order to appreciate the improvements. Then we talk about mortality, right? We know there is a risk of death with epilepsy. We know sudden unexpected death exists. There's a 2 to 3-fold increase in death rate in people who have epilepsy, and if you have drug-resistant epilepsy, it's 5 times or more. In general, if epilepsy surgery renders you seizure-free, your mortality risk is as the general population. So if we can make the seizures go away, we can basically take that risk away. But even if we reduce the seizures, we can reduce that risk. So the SUDEP rate after epilepsy surgery in this study I put there at the bottom was 1.9 out of 1,000 versus 4.6 out of 1,000 in those that didn't have surgery. And that's for all calls. And then there's the cost question. So people always bring up how expensive it is to do epilepsy surgery evaluations, which it is, that's true. but patients with drug-resistant epilepsy account for 50 to 80% of the cost of epilepsy care in the United States. That care is office visits, that care is all the medicines, that care is mom and dad can't go to work, that care is all the people that you got to get to help you out with therapies or help you out around the house. There's a lot of intangible costs that we can't even put a dollar value on. So it's quite an expensive thing to have epilepsy that's drug resistant. If we can do epilepsy surgery and see some improvement, you can see reductions in those things. And in fact, you can recoup the cost over time. This one study, which again doesn't look at LGS, it looks at other types of epilepsy surgery, but said in about a decade you recoup the cost. The earlier you do it, the sooner you recoup those costs. So let's talk about what would be involved if you decided you want to do a surgery evaluation. First of all, epilepsy surgery evaluations should be a team effort. If it is not a team effort, I suggest you turn around and walk back out and go somewhere else, because it is not a one-person show. There needs to be a clear team involved. That team is epileptologists, that is the neurosurgeons, there are neuroradiologists, neuropsychologists, child life, EMU staff, social workers, case managers. There's all kinds of people that need to be involved in this. Typically, you're going to go with something called a phase 1 evaluation. That's what we call it. Phase 1 evaluation for most people is on average 5 to 7 day hospitalization. And depending on where you go, it depends on how it's going to be done. If you come to my hospital, and Dr. Lamb's, I suspect, is very similar to this. We bring you in, we've got everything planned. We try to get it all knocked out in one fell swoop in 1 week, get everything done. Some places will do the video EEG in-house, and then all the ancillary studies will be done piece by piece on an outpatient basis. But those are the ways that can be done. When we do this, the most important component to start is usually the video EEG, right? So we're doing a video EEG because we want to get careful video and EEG evidence of the seizures. We need to understand exactly what seizure types you have, and we're doing that because we're trying to determine, are they focal, meaning they're coming from one area of the brain, or are they generalized, coming from the whole brain, or are they multifocal? So there's foci, but there's multiple of them. This is really important in Lennox-Gastaut syndrome because one of the seizure types a lot of people with LGS deal with are tonic-type seizures, right? So they come, their arms get tight, or generalized tonic-clonic seizures where you might not really have any clue from the seizure itself that it's focal. But if we can get it on video and we can watch it, you take a video of a seizure and start to watch it in very slow motion, you can start to pick up things that you can't pick up in like day-to-day life. That one arm consistently always moves before the other arm moves, or the head always has a deviation to one side, or the eyes do, that maybe other people you just can't pick up at real speed. Plus, you've got the EEG to take with it to try to see, does that focus exist? And then, again, in a case really multifocal, then being able to understand the proportion of multifocality. So just as an example, let's say you have seizures from both the right and the left hemisphere. I may be interested in, well, are 90% from the left and 10% are from the right, because that may impact how we decide what we're going to do from a surgical basis. So that's what the video EEG is about. Of course, you're going to get an MRI. The MRI is generally high resolution, 3T magnet study. This is the phase 1 MRIs are MRIs that take very thin slices, so usually like a millimeter of each slice, as opposed to typical MRIs, which may be 3 to 5 millimeters. You may get something like a PET scan. So a PET scan is it's basically a study where we inject sugar, basically radio-labeled sugar. The brain takes sugar. The brain needs to make energy out of that sugar. Areas of the brain that cause seizures don't metabolize and make energy normally, and so they look different on a PET scan than healthy areas of the brain. And these are studies we might use, for instance, if your kid had a normal MRI and we thought there was a focal onset, then we could do a PET scan to see if we could find the area where the metabolism is different to suggest to us that that's where the seizures are coming from. We might also do SPECT, or single photon emission computed tomography. This is basically where we have to wait for a seizure to happen, and when the seizure happens, they inject an isotope. That isotope is taken by the blood. It gets deposited into the brain where the most blood flow is being taken to, right? So wherever the seizure is coming from in the brain, it's going to want to use the most blood and most energy because it's doing the most exercise. And so more isotope gets deposited there. So we do this scan We inject somebody when they're having a seizure, and then we do the scan on another day when they're not having a seizure, and we compare the two to each other to try to figure out where the max blood flow is. We may do functional MRI. Functional MRI is where we basically, you're in a scanner and we're doing different paradigms. So for instance, we might, if the patient is able, have them, move their, left hand over and over and over again. And we are looking at the consumption of oxygen by the brain, because just like a SPECT scan, whichever part of the brain is responsible for that hand moving is going to use the most blood. If it uses the most blood, it's going to use the most oxygen, and so that we can pick it up that way. So we can map language, we can map sensory, we can map motor this way. This does require patient cooperation, so a lot of times in LGS, this is not what we're doing. There are some ways we can do it without patient cooperation, so we can do sensory without that. We can stimulate the fingers with little puffs of air and stuff like that and see where sensory is. We can do paradigms like listening to a story, where sometimes we'll have the parent read a story. It's a familiar voice to the kid. They're sedated, but not so much that they can't hear, and so we can get an idea of which side is recognizing the language. So there are some methods to do it, not perfect. Then there's magnetoencephalography, also called MEG scan. So some people may use a MEG scan. MEG scans are kind of an extension of EEG. So what EEG does is it looks at electrical potentials, electrical fields that the neurons are making. The problem with electrical fields is that when they leave your brain and they go through your skull and they go through muscle and they go through skin to get out to those EEG leads, they can be dispersed. And so what may be coming from a small area on EEG maybe looks wider, or maybe what's coming from a small area could potentially disappear as it works its way out leads. Any of you that took physics may remember when they taught you to do this thing with your hand, because every electrical field has a magnetic field that is perpendicular to it. The thing about magnetic fields is that magnetic fields do not change. So magnetic fields outside of the brain look just like the magnetic fields inside the brain. So that's what MEG does. MEG is picking up the magnetic field created by all this electrical activity, and then we solve a reverse equation, basically. Say, here are the magnetic fields, now let us calculate where those magnetic fields were generated from. And so when we do this study, we get back something with like little dots on it that tells us that this is where these abnormal waveforms were being generated from. Another thing you might get is high-density EEG. So I don't know if any of you had that, but that's 256 EEG channels. That's very different from the 21 channels you might be used to in a typical EEG. The idea here is that the closer you place the leads and the more leads you place, the more likely you're going to be able to find something that, again, might get missed as things get dispersed. This looks like it's a lot harder to do than it is. This is actually a netted cap, and so it's actually quite easy for us to do. We dip it in a solution and we put it over the head and we're done. It's on. It's like the fastest, it's much faster than putting on a 21 lead EEG, actually. And then so once we get all of that, all right, and every evaluation is going to be different. Most evaluations for Lennox-Gastaut syndrome are not going to include all those tests. If you go in and there's something about the EEG that looks focal, then they may pursue a PET, they may pursue a MEG, they may pursue a SPECT scan. But if it looks like a clearly generalized seizure, which is very typical in LGS, then they may not pursue all that. They're going to get an EEG, they're going to get an MRI, and then that's probably the end of the game there. I mean, as far as the workup goes, they don't need those other things. But what will happen then is the team will meet, they'll take all that data, they'll meet, they'll discuss the case, hopefully in great detail. They'll argue back and forth about what's the best thing to do. Everyone will pontificate about what they think is, their experience, yada, 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 and then we will come to a conclusion about what we think we should do. And that conclusion is you're either a surgery candidate or you're not a surgery candidate. And if you are a surgery candidate, how are we going to go about doing it? And so sometimes there are invasive procedures that we have to do, invasive monitoring. So some people, we will work them up. We'll say we know exactly where it's coming from. It doesn't look like it's close to anything that's, I'll use the word important, though the entire brain is important, but like motor function, language function, things, it's far enough from that we can do a surgery safely. We don't need to do anything else. Let's just go do surgery. And then there'll be some people where we say, it's in this area. We're not exactly sure. We want the smallest area in that area as possible. Or it's really close to something important, so we want to make sure we're not hurting anything important. For those people, we have to do invasive monitoring, where we actually take electrodes, Similar to the electrodes you have on a regular EEG, except now we're putting them directly on or in the brain to monitor those areas to try to figure out the smallest area. So that's called a two-stage procedure, or invasive EEG monitoring. There's a few ways we do it. One is by strips and grids, which is what we see here. These are basically just sheets of electrodes. So we do a craniotomy. We open the skull up, expose the part of the brain we want to monitor, put the grid on top of it, and then read EEG for days in the EMU until we collect the seizure. The other way we do it, and then probably the more common way you're going to see it done now, is something called Stereo-EEG. So Stereo-EEG uses depth electrodes, which are basically like piano wires that we stick into the brain to monitor different areas of the brain that we want to. The reason that's important is because, as you know, the brain has all these curves, right, that make it up. Well, a grid covers the outside, and that's only 25% of the brain. 75% of the brain is down in those curves. And so the better way to get to that is by using depth electrodes. Also, what's great about depth electrodes in Stereo-EEG is it avoids the need for a big craniotomy, because the way Stereo-EEG leads are put in, we plan where we want to put them, and then using robot guidance is how we implant them. So Dr. Lamb would go into the operating room, the robot would position her where it needs, exactly in the angle that the electrode needs to go. She'll make a burr hole, which is just a small hole in the skull, and then open the dura, or the covering of the brain, and then place the electrode exactly where it needs to be placed, and then bolt it in. And then you go to the EMU, and we monitor. And that allows us to monitor deep areas of the brain that we might not have been able to get to with strips. It allows us to monitor multiple areas at one time. So I can monitor, the outside plus the inside with one electrode that I couldn't have done with a grid. It also lets us monitor big areas. So we can monitor both sides of the brain or lots of areas of the brain, which before we could do with grids. But to have to do a craniotomy and remove the skull on both sides and put all these, that's a really, really, really invasive thing to do. So if we can do this with all these little electrodes, it's a much easier way to go about it. So this is just kind of a breakdown of how it works. We identify what we want to, when you hit, the neurosurgeon and the epileptologist meet and kind of figure out exactly how those electrodes are going to get implanted. We let Rosa, the robot, do their thing, and then we get them put in. This particular picture, the patient down the bottom, that's what the electrodes look like when you come out. You won't see it because it'll be all wrapped up, so you wouldn't see it anyway. This particular person had their head shaved. We do not actually, we don't shave heads. I don't think, Sandy, y'all don't do that either, right? We don't shave kids' heads to put in electrodes. We just part the hair. So that's also some people's really big concern about epilepsy surgery, is the loss of their hair being shaved. So I'll just put that out there. So then we do that, and then we get to the point of, all right, what are we going to do? Like, we monitored it. We've now got the data that's smallest. What can we do? Man, in a great scenario, maybe you're a candidate for laser ablation. Laser ablation is a similar process to what I described. We have identified a small area of the brain that is a problem. We can insert a laser. The laser then heats up, right? The brain will survive at certain temperatures, and then it will get to a certain temperature where the brain will die. And that's what laser ablation does. So we put the laser in. It is MRI guided, so we're running the MRI while we're doing it. The laser heats up the brain, and it heats up the area we want to basically kill to the temperature that brain can't survive at. And then it has safety triggers around it, so we say, we want this part of the brain to get this hot, but these areas cannot get hot because we want to preserve those. And it's all under guidance. So it's a great way to do a very small focal ablation. Fact is, most people with Lennox-Gastaut syndrome aren't going to have very small lesions. So this is not going to be that frequently used unless we use it for corpus callosotomy, which I'll talk about in a few slides. All right, so that's that. Responsive neurostimulation. You guys have probably heard a lot about this. This is something really exciting. So responsive neurostimulation is just what it sounds like. So we are stimulating the brain, right, to change the way the brain activity is occurring, and it's responsive. So it is responding to something. So this is the device is basically a little computer, okay, that gets implanted into the skull. It's flush with the skull, so you don't see it or anything. And then those two wires that we have, those have electrodes on them, and so we implant those electrodes over the area that the seizures come from. So if you have LGS and we've identified a focal area of the brain that's causing it, we could implant electrodes over that focal area. and it's going to read that EEG, and when it sees an EEG, or it sees a seizure happen on the EEG, then it activates and stimulates the brain to try to stop it. So it fires over and over again to try to make it quit. More often than not in Lennox-Gastaut syndrome, we are implanting these into the thalamus. So the thalamus is like the center part of the brain. Think of the thalamus as like your power strip at home that all your lamp cords are plugged into, okay? Everything from the brain goes down into the thalamus. And there's a nucleus there called the centromedian nucleus, and that's a nucleus that's highly involved in the EEG networks of generalized epilepsies, of which LGS often is. So we put these depth electrodes down into that nucleus, and it does the same thing. We can read and see when a seizure occurs, and it stimulates that nucleus to try to interrupt it and stop the seizures. So that's an exciting thing that's come around in the last several years, giving us yet more candidates for epilepsy surgery. There is an ongoing trial in Lennox-Gastaut syndrome. In that trial, they're doing this a little bit differently, so they're actually implanting 2 RNSs, one on each side. They will have one lead in the thalamus, and then they also do a strip over the prefrontal cortex. The reason for that is because there may be some discussions tomorrow about this, but that came from some data that basically revealed that in LGS, the thalamus is a hot spot, but probably also the posterior frontal cortex is another part of that network, and so they're trying to stimulate both of those areas. You can also do deep brain stimulation. So deep brain stimulation, very similar to responsive neurostimulation. You're planting electrodes down into the thalamus to the centromedian nucleus. The difference with deep brain stimulation is that it's always stimulating. So it's stimulating off and on all day, kind of like a VNS does. It's always doing something. So it's not reacting, it's always stimulating, with the idea that if you're always stimulating, maybe it just never happens to start with. There have been some studies that I'll show in the next for DBS experience with centromedian nucleus responder rates. Again, that's 50% reduction in about 60% of the patients, and generalized tonic-clonic seizures did best. This is a meta-analysis that combined a lot of studies of LGS, centromedian nucleus, DBS, mean seizure reduction, average seizure reduction, 63%. 81% of patients that had the DBS had a 50% or greater reduction. So again, compare that to some of the other options we have. 88% quality of life improvements, complications only 5%. I just put this up here because I think this is something that's going to be kind of exciting as well. This is something called chronic subthreshold stimulation. So in this approach, we will have identified an area, maybe a network of multiple areas of the brain that are causing the problem. And what we will do is we will implant electrodes in as many of those areas as we can. And stimulate all of those areas constantly. So it's kind of like DBS, because we're stimulating all the time, except we're stimulating a whole network of abnormality. And so that's something that's going to likely be entering clinical trials later this year. Okay, lastly, I think, in surgery-wise, I want to just talk about corpus callosotomies, because this is something that a lot of you, if you're being talked to about surgery, think about. Corpus callosotomy the corpus callosum is that bundle of wires basically that connects the left and the right hemisphere together. It's an important structure, but for people who have tonic seizures, atonic seizures, and other generalized seizures, it also is the conduit to take bad electricity from one side of your brain and make you fall. And so we can disrupt that by cutting that bundle of fibers in half and disconnecting the left and the right brain from each other that way. When we do that, there are potential for complications. You can have what is called a disconnection syndrome. Disconnection syndrome, you may have some difficulty speaking. You may have some difficulty with transfer task and left recognition. You may have some difficulty with coordination of gait. Most of these things are things that are recoverable from a rehabilitation standpoint. So you may have some period of hospitalization for rehab after this, but they are recoverable things for the overwhelming majority. There are 3 basic ways we do corpus callosotomies as far as the method by which we disconnect the fibers. One is laser therapy, as we were talking about before, where we, I'm sorry, what word am I supposed to use? We don't kill the fibers. What do? We we remove the wart that is the corpus callosum, okay? So the thing about laser ablation, the laser is a straight object, the corpus callosum is a curved object, okay? So in order to curve with a straight object, you have to make multiple passes in order to make a curve. So the downside of laser ablation is that it's going to take longer to do because you got to plan each one of those, those approaches in the operating room. But it's quite minimally invasive. I mean, you come out with the small hole that the laser went through, and recovery is quite nice. You have the traditional approach, which is a frontal craniotomy, so removing the front skull plate to expose the brain, and then making the disconnection. And then you have an approach that, this is, Sandy, you use the third approach just like we do, right? Which is an endoscopic or mini craniotomy approach, where they make a small incision at the vertex or top of the skull, and then go straight down and disconnect back and forth. So again, a less invasive approach altogether. All right, I'm going to try to finish up here quickly because I want plenty of time for us to talk about questions and stuff. But the last thing I want to do is I just want to talk about getting better answers. As I said, I am part of something called the Pediatric Epilepsy Research Consortium. Sandy and her folks at Lurie Children's are also part of this. In 2018, I founded the Epilepsy Surgery Database Project. So this is currently now 29 pediatric epilepsy centers as of just the other day, who collect data on children who are referred for epilepsy surgery, whether they go to the operating room or not, because we're quite interested in who gets accepted as an epilepsy surgery candidate, and we know they're not the same people at every single institution. You may go to one place and they tell you you're not a candidate, and you go to another place and they tell you you are a candidate, because it just depends on the comfort level that they have. But over the years, we have amassed now 36 who have been evaluated for epilepsy surgery, and we've looked at a few things that I think are of interest to people with Lennox-Gastaut. Okay, first is looking at delays to surgery. So we took our whole population and we looked at people who had failed more than 3 seizure meds before they were referred for epilepsy surgery, just to see what are the characteristics of these people. Why did they fail more than 3 meds before they got sent? And the characteristics of those people is that they often were undergoing surgeries that had palliative intent, so they were undergoing surgeries that weren't intended to make them seizure-free, so people waited longer. They had early onset seizures. Oftentimes younger kids get delayed because people are nervous to operate on very small children, or they think maybe if we wait for a while, something's going to change, they're going to outgrow it, something like that's going to happen. And they had abnormal neuro exams. So for whatever reason, people who have abnormal neurologic examinations often get delayed. I think some of that reason is people like, well, they've got bad epilepsy and cerebral palsy, so I can't fix that. Yes, you can make that better. But I do think that's what happens. We also looked at, to be fair, looked at time, because you could fail 3 seizure medicines in a week, and that doesn't mean you were actually delayed for surgery. You might just had a bad week in the hospital. So we looked at people who, once they're diagnosed with drug-resistant epilepsy, it was over a year before anyone referred them for epilepsy surgery. And again, we found very similar things. That they were younger when they had drug-resistant epilepsy, they were younger when their epilepsy started, so they tended to be delayed. And so then we asked, well, was that worth it? So we looked at these people that were delayed, and the Engel criteria this is a simplified Engel criteria. So Engel 3 and up is 50% seizure reduction, 90% seizure reduction, and seizure-free. And what you see is that in both of those groups, after these procedures, 70% of the people had 50% or greater reduction in the seizures. So waiting was a waste of time, really, in my opinion. Like, it could have been done sooner, and they could have been experiencing 70% reduction earlier in life. This study compared people in the database who were referred and accepted for palliative versus definitive surgeries, just to look at what are the differences between people that take these paths. Very similar. People who undergo palliative procedures are generally younger when their seizures start. They generally are waiting twice as long as a person undergoing a definitive surgery to be evaluated. They have failed more medications. And they tend to have generalized and multifocal seizures. So those are the kinds of people. So again, to me, those are just red flags for healthcare providers to look out for, to think, I should be thinking about this a little bit sooner in these kids. This was a study we did recently where we compared those 3 methods of doing corpus callosotomy. We didn't have enough patients to really show there was any difference in outcome. So numerically, open did better than endoscopic, did better than lit, but there's not enough patients in this group to say that's statistically significant. So I would say that the outcomes are very similar for all 3 approaches. What's different is some of the kind of surgical complication things. So as I said, going to be in the operating room longer with laser ablation than you are the other 2, But on the flip side, blood loss is higher with an open procedure than it is with a laser. You are more likely to be readmitted if you have an open surgery within 30 days than if you have one of the other procedures. Interestingly, the amount of time you're in the hospital after the procedure is not different. So you would think if you do a minimally invasive thing, you ought to get out faster. But the fact is the reason people stay in the hospital after corpus callosotomies is because they need rehab. And so all of these procedures cut your corpus callosum in half, so they're all going to have the same need for rehab. So there's no difference there. This was one of my favorites because I'm also a genetic epilepsy person, and that's surgery in people with genetic epilepsies, because oftentimes what happens to a person who has a genetic epilepsy is they're automatically considered not a candidate for epilepsy surgery because surgery is not going to fix your genetic problem. But that's not the goal. The goal is to reduce the seizures as much as possible compared to your other options. So we looked at the patients in the database who had genetic etiologies that underwent surgery, and what I'll point out is that 66% of people overall had at least a 50% reduction, and most importantly, 86% of the people who had single gene non-lesional genetic epilepsy. So these are people who have epilepsies like SCN8A associated epilepsy or KCNT1 or SCN1A Dravet syndrome, things like that. They still benefit from surgery even though we didn't fix the genetic problem. Now, this is also the next passion of mine, which is to make people understand that there's more to epilepsy surgery than seizure control. Especially when we're talking about things that aren't going to make you seizure-free, we need to focus on other things, and that is the non-seizure outcomes. So the database holds neuropsychology data of children undergoing epilepsy surgery, and Madison Burrell, who's at Children's National, runs this portion of the database. And what's important is, first of all, palliative epilepsy. People who are undergoing palliative procedures, only 39% of them had any kind of neuropsych testing, whereas over 60% of people undergoing definitive surgeries do. Why is that? Well, a lot of people who are undergoing palliative procedures have maybe low functional cognitive status, right? And they're undergoing a palliative procedure. So the thought is, I'm not going to make them seizure-free, and they have low functioning anyway, so that's not our goal. But it should be. It should be our goal to see if we're making any changes. Now, there are some shortcomings because the kinds of tests we do are not really designed for people who have developmental epileptic encephalopathies. So a lot of the standardized tests we do, if any of you have been in clinical trials or done them, you get very frustrated with them because they're like long list of, my kid does this, my kid does this, and you're like, nope, 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 stop asking these questions. Like, but my kid does do this and this and this, but you didn't ask me about that, right? So we do have to come up with better scales. There is a project out there called the Inchstone Project that is trying to develop better scales because kids with developmental epileptic encephalopathies don't achieve milestones all the time. They achieve inchstones, but they're still important things, and we need to be able to measure them. And so that's something else we're working on. But I do hope that with this work we can ultimately show there's more to it than just seizure reduction. There's other improvements. Okay, so we're going to conclude so that we can chat about surgery some more. But basically, I'm going to tell you, epilepsy surgery is underutilized. It's been that way for a long time. It's getting better. It's got a long way to go. There are numerous barriers to epilepsy surgery evaluation. Most of those are misconception of the value of epilepsy surgery and the risk of epilepsy surgery. I think people overestimate the risk of brain surgery. I don't blame you. Brain surgery is a big deal. I get it. But it can be done safely. I think epilepsy surgery offers us many benefits, many times benefits that exceed those that we can have with other medicines, etc. You deserve the opportunity to hear about that versus all of your choices and to choose which one is best for you. At the rate we're going with all these new surgical techniques, almost everyone's a candidate for epilepsy surgery in some way. Again, it's not going to be the best choice for everybody, but almost everybody has something they can do. And finally, the way to solve these problems and to answer all the really, really good questions you guys have when you come to your doctor's office are to do things like PERC, in my opinion, and to have all the epilepsy centers collecting the same data together, comparing ourselves to each other to figure out who's doing it the right way so that we do it better. And with that, it's a free-for-all. Now we'll ask questions. Thank you. Okay, do we have a second mic, or do I need to just take this mic around, Maury Povich style? Yeah. Where do I go? Here, all right.
Thank you. My question is how do we get the doctors to let us have a choice? Like, I'm more for the RNS because I love that it's like a built-in EEG. It takes a picture of the brain a minute before the seizure, a minute after, and then every day you upload everything into a cloud where your neurologist sees it every day. So I'm a big fan of the RNS. Well, one of my guys went to the doctor, the surgeon, the other day, and I said, can he get the RNS? And he says, no, that's the last resort. My daughter got it because it was critical. It was the last resort. So he has to get the deep brain stimulator. So how do we get doctors to do what we feel is best that's going to benefit them?
Okay, so first of all, the doctor can log in every day and look at the EEG, but if you think I'm logging in every day and looking at EEG, no, I'm not. I don't want to burst your bubble, but that's not what I'm doing. I look at it like once every couple months. But, I don't know. That's a personality thing, That's just a personality thing. You got to have a person who's willing to hear it, and they may have a very, very good reason for their answer, You just need them to explain that. So you just have to, as nicely as you can, say, can you explain to me why? Why? No, yeah, it's not a last resort. That's a terrible, no. It's not a last resort. But why are you choosing this one over this one? Just explain it to me. If I don't understand, I'll tell you I don't understand, but I deserve the opportunity to hear why you think one thing is better than the other. And it's, I think it's tough for physicians because they've probably got, a long list of people waiting in rooms that they need to get to. And God forbid we have to stop and try to explain to you the thought process that we have. Just trust us. We know what we're doing. But you deserve the opportunity to hear why it's happening. So.
Everybody has a different style for care teams and really who you bond with and who you trust. But fundamentally, this is your loved one, right? So you need to trust them. So just like Dr. Perry said, if you go in and you notice there's a team, then that's not the place for you, right?
Yep.
And then the other thing is, sometimes honestly the answer is I don't know,
Right.
or we don't know yet, and it's sometimes very difficult to convey that, right? Is we know all this stuff, but ultimately we don't actually know what is the right answer for you right now.
Yep.
But let's learn together.
Or they might not be, it might be, as I said, they might not be comfortable with it. RNS, because that's what I'm comfortable programming. I'm not comfortable programming DBS.
RNS is so much more expensive than everything else. So I think that
No, they're not. They're all expensive. They're all expensive. Nobody's got a coupon for one of those. Just don't even worry about that. But the other thing is, honestly, and if you don't get that answer, then it's okay to go get someone else to give you an answer. There's nothing wrong with a second, third opinion. Maybe a fifth, sixth, and seventh opinion. I mean, maybe if you've been told the same thing 4 times, maybe we're good. I don't know. But there's nothing wrong with asking, to get it. And frankly, if you're seeing somebody who doesn't want to let you get a second opinion, that also is a red flag.
So 2 quick questions for you. One, the slide you had earlier that was pediatric epilepsy, was that research centers? I was trying to, what's the link? Because I wanted to jot that down. Because you had a map that showed the centers around the country that was participating.
Yeah, as I said,
Pediatric Epilepsy Research Consortium. Okay.
Yeah, so PERC, again, PERC is a national organization in the United States. It's 75 plus epilepsy centers in the U.S., and as I said, over 500 researchers. So it includes neurosurgeons, neurologists, epileptologists, neuropsychologists, PhD researchers, et cetera, who basically have just agreed to work together. And it's not just for surgery. Surgery is the special interest group I'm part of, but PERC has a group dedicated to Lennox-Gastaut syndrome. We have a group dedicated to early life epilepsy. We have a group dedicated to health equity, to telehealth. We have special interest groups for everything. And the whole concept here is we're done with doing individual center specific, I'm tired of reading your paper that's how you did it there, good for you, but this patient is over here, so how are we going to do it over here? So it's more about national, these are the ways to do things.
And then the second question I had was about the central median thalamic RNS. So my son is 12, and what his epileptologist has told us is that she would recommend that as the next option. However, it's only approved for 18 and older, but they've been doing it in patients that are younger. So do you have experience with that? Like, what's your...
Yeah, so that, like many things we do in pediatrics, isn't always indicated by the FDA in pediatrics, but it doesn't mean we can't do it. So it may mean we try to do it and the insurance company says no because, you know, you're not under 18, you're under 18, but we just have a conversation.
What you were saying before about the earlier that you try, I guess that's what I'm thinking is like the earlier you try to do something, but yet it's not approved.
Yeah, it's not even about the age in this case, right? Because what they studied it in was focal epilepsy to start with. That's what it's approved for. It's approved for the treatment of focal epilepsy in people 18 and up. We have no reason to believe that the safety is any different in children than it is in adults, you know, except maybe in very, very small children, but in, you know, older children, no reason it won't work. What we don't know is how useful is it for generalized epilepsy, because that wasn't the trial. But we have mounting evidence that it is useful. And frankly, the only way to get that evidence is to do it. There is a trial, as I said, for Lennox-Gastaut syndrome, where they're actually doing it differently than what I described, where they're implanting 2 of them. Maybe we'll see. Maybe that's a better approach than the approach we're taking by just doing this.
For most, and that's for epilepsy surgery, heart market, and then doctors try to work together with families for the best thing for your loved one. But then we have the regulatory thing, which is, oh, it was approved for age 18 and older, but you know what? That clinical trial and approval never met your loved one, right? So the level of comfort where our centers are, and we often put in devices in much younger patients. So it is kind of a practice pattern for where you are in your care team. But there's nothing that will say, no, you can't. So.
Yeah, I was going to say, I know there's a 5-year-old in the database. So that's the other thing I was going to say. That's the purpose. That's one of the purposes of this kind of study, right? So the FDA has indicated that they are open to the idea of real-world data to be able to expand indications. The thing about real-world data is it needs to be good real-world data, decent real-world data. So, you know, projects like this that are trying to collect the same things every place is, instead of waiting 20 years for me to have 100 RNS cases at Cook Children's, I can have 100 cases in, you know, 6 months with 29 sites.
But you can put VNS younger individuals. And then the other thing to think about is growth, right? So a baby brain is actually a different size than a school-age child or an adult. But actually, you are 87% of your head growth by age 2. So really, there's not that much more growth, and that's why, to us, a 5-year-old was completely fair.
We had a 9-year-old have a corpus callosotomy just over a year ago and had dramatically reduced seizures, probably like 90%. But the seizures that he does have, they're now few and far between, but when they happen, they're really severe. Like we're getting in an ambulance pretty much every time. And so we've been working with Dr. Shahani at Cook to right now, we're treating with medication, but he's talked about possibly doing another surgery beyond the corpus callosotomy because the change in seizure, particularly because now whenever he's having them, he's kind of like trailing off to one side, and that might be an indication of something else. what, he's talked to us a little bit about what those surgery options are, but I guess I'd just like to hear a little bit about, like, what would the treatment for something, if they can how would they determine if it's focal? I think you covered it here a little bit. And, like, are there success rates or, like, any information around that?
All good questions that I can't answer with all the data, unfortunately, right? But what may have happened is you had what appeared to be very generalized seizures. We've done a callosotomy now where we've disconnected the highway between the two hemispheres, and it's now becoming clear that one hemisphere is actually the cause of the problem, right? We've uncovered that. So we would probably repeat a phase 1 and include something like a MEG scan, maybe a PET, maybe SPECT. I don't know. It depends on the seizure type, the EEG appearance, to try to see, can we recognize where within that hemisphere is the problem, or at least narrow it down to an area. That then may include the invasive monitoring. We may have to go in and monitor to get to the smallest area possible, and then it's a matter of, if it's really small and we can do it with laser, maybe we'll do it with laser. If it's a bigger area, maybe we'll need to remove it. If it's an area that we can't remove or we just prefer not to remove it, maybe we put a neurostimulator over it to try to stimulate it. So, almost all of those things are on the table until we get through it and try to see. What we don't want to see is we don't want to bring you in and capture seizures and find out some are from the left and some are from the right. Doesn't mean we don't have plans for that. There are things we can do. That's just not ideal. Yeah.
For all 6 of those ambulance rides,
Yeah.
that CC was immaculate.
Good.
His talking, his colors, nothing short of miraculous.
Oh.
He's not as aggressive.
Awesome. We love hearing that. Zombies don't always work. There are people they don't work in, but I do think they are very, very useful.
No, they don't.
So I just wanted to ask, so for patients that have had a VNS for more than 2 years and there's been no positive change, is there any data to support that an RNS or a DBS type situation, even though it's still neuromodulation, is beneficial or productive?
Well, I would say there's no reason why we would not think it should be, right? VNS is great, but VNS is a nerve down here that's attached to the brain that's doing a bunch of neuromodulation. So these other neuromodulation techniques are getting closer and closer to a source. So if we're going directly to what we believe is the source, I would have no reason to believe you shouldn't have an opportunity to improve with it. You may still improve with VNS over time, right? It can take years and years and years to continue to see improvement, but it's hard to know. Yeah, who knows? Yeah.
Do you want to speak to the synergistic or, more than additive effects?
That's your subject matter is VNS. So one of your subject matters is VNS. But yeah, there is potential that, the devices together have benefit, right? We know there's benefit to VNS and a callosotomy, So sometimes it's cumulative to add these things.
Hi. So back in 2018, my daughter had a full callosotomy and, went through extensive physical therapy and stuff to learn how to walk and talk all over again. There are some other side effects that they don't talk about, though, in like your brain getting in a loop, like she's trying to write something and she can't make the letter even though she knows what she needs to write. So we continue to practice writing and things like that to get things to talk, right? Your left and right side to talk to each other and your brain to talk. She also has a VNS implant. She also has all these other medications and everything working together. We're getting a lot better than it was. My question specifically about the corpus callosotomy is I understand now there is a type of corpus callosotomy that does not involve the entire cutting so that possibly you can reduce some of these side effects and still gain the benefits of the separation between the two halves. Could you speak about that a little bit?
Yes, you're absolutely correct. There are a couple ways to callosotomy. That was on one of the slides, but I didn't really point it out. So there's anterior callosotomies, anterior two-third callosotomies, which is exactly what it sounds like. We disconnect the anterior two-thirds. There's posterior one-third callosotomy, complete. When you compare the three procedures to each other from a seizure control standpoint, complete callosotomies are the best. They have the best seizure control. Anterior callosotomy is probably next and posterior last. The reason they came about mostly is because what you described is the idea was, man, if you could disconnect the anterior portion and leave some of the motor stuff connected in the back, maybe you won't have these gait problems, maybe you won't have some of this left-right apraxia, those kinds of things. And it's true those risks are probably less with that, but so is seizure control. And so it's really it's a patient-specific discussion. So if I have a patient that needs a callosotomy that functionally is walking, running, carrying on conversations, feeding themselves, things like that, we will talk about, hey, there's not as good seizure reduction with an anterior one. Do well with that. So given how functionally well they're doing, if we want to try to avoid that risk, let's do an anterior two-thirds. You can always go back and get the last third if you need to. If it doesn't work, you can't put it back once you've disconnected it. So it really just depends. That's the main thing I would say. The posteriors were done in the concept of trying to improve behavioral adverse effects that some people have. So if you leave the frontal lobes connected, maybe behavior will be better, and you just disconnect the back part where the motor kind of connections are. I have rarely done a posterior in a patient. I've not been happy with any of them that I've did, but I mean, it could just be patient selection because I so rarely do them. And when I say me, I mean my surgeon, Dr. Hansen, not me. I don't do them.
You mentioned how every anti-seizure medication after the first two just becomes less and less likely to help a patient. I'm curious if there's any change in that responsiveness to medications after a corpus callosotomy or any of the DNS, DBS, RNS, and when you consider retrialing medications after those, like if patients aren't seizure-free after those surgeries.
So that was a very good question. So first of all, I want to start. I say that the percentage of seizure freedom goes down, 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 and that is true. But it doesn't mean it's zero. First of all, so there's always a chance that you'll find that magic medicine. And I have found the 6th, 7th, or 8th medicine that has made a person significantly seizure reduced. So don't take me wrong and give up on that concept either. Especially if you have an etiology where there's a certain medicine that's very specific for it, So if you've got Lennox-Gastaut syndrome, but it's because of SCN8A encephalopathy, we know sodium channel drugs work very well in those kids. So you should really try sodium channel drugs, So keep that in mind. I would say yes, after a surgery is done, you've had some reduction, you have maybe some seizures come back that you want to treat. I don't have any recipe as to when I go back, but I think it's completely fair game to consider drugs that have failed in the past and go back and try them again because you've changed the landscape of the brain now. And so it may be a whole different story when you go try it again. And I've definitely seen that, and especially in a few callosotomy patients where there's a clear need for the medicine that they're on. It's clearly doing something in addition to the callosotomy. That was the magic they needed. I mean, it is fair, yes. The question is it fair to say that a callosotomy is irreversible? Yes, that's fair. We cannot connect the callosum back once it's been disconnected. Is the DBS or the RNS reversible? I mean, we can take the stuff out. We've put it through the nucleus to some degree, so there is, we have done some damage, but, I mean, it's mild. I don't know. Sandy, what do you think? It's like a wart. Explain that to her. Explain that.
I guess we have the concept of like minimally invasive, right? But maximally invasive, right? I mean, there's so anything that goes through the brain, right? Whether it is a super tiny piano wire or kind of like a bigger thing with big surgical instruments, it's still your loved one's brain, right? So, putting in electrodes into the brain for stereo-EEG or DBS or RNS, it's still something that we do to the brain, right? So yet, yes, you can take the electrodes out, but we've already actually cut the skin, drilled a hole in the skull, and actually put something through the brain. So I don't want to minimize that, even though, I'm trying to say that brain surgery is not scary if it's done for the right reasons and done with shared decision-making and with care, right? So yeah, I guess I wouldn't minimize putting something in the brain and saying, if it doesn't work, I'm just going to take it out because we've committed to putting something through the brain. So it really is just kind of what makes sense. Like, can we all stand behind this? Can we all look each other in the eye and say with conviction, I believe this is going to help? So maximally effective, minimally invasive is maybe what we're going for, but it's still something that we do.
So something that's I'm having trouble wrapping my head around, and you spoke a little bit about this when you used the word palliative, is that for me, so my son has the VNS, and like I felt like that was like the first, I'm like stepping in, putting my toes in the water. We'll try that, and we'll get the battery replaced, and we'll kind of do that. When I hear the word palliative and RNS, right, part of me thinks, am I going to go through this undertaking and there's risks involved, right? And it's not going to cure his seizures. I guess one of the things I thought about with the RNS or the DBS is they still have seizures. They're still having the seizure, but is it that the device is stopping it sooner to minimize the damage? I don't know. Maybe you can kind of help me wrap my brain around.
Yeah. Well, the concept with the RNS is it's going to act, hopefully it will act so quickly that the clinical manifestations of the seizure, you don't even notice, because see it, stimulate it, stop it, or at least make it so short that, if it's a seizure that was resulting in a fall, for example, maybe, it's a quick jerk, but we don't fall because it's not going on. That's the concept. DBS is always going, never starts to start with. But yeah, your point is well taken. We have this conversation over and over again with families where they're like, we've been through a lot in life. The child's been through a lot in life, and I don't know if it's going to work or not. So is it worth putting them through all of this for something that's not going to work? And the problem is we can't predict the future. Again, why projects like this are important, because if I can give you good statistics and say that across thousands of people, this is generally what happens. It's still not perfect, but it's better than just my own experience, or what I read in a paper from somebody else's experience. It helps, but it is a hard decision. But at the same time, a lot of times I tell people, when we're talking about surgery and we're concerned, is this going to be good enough or not, we'll say, okay, but what about our other option? Is that going to be good enough or not? I know it's easy to give a medicine, but if you know the likelihood of that medicine doing anything is pretty clear, is it? I don't know. Yep.
I know that deep brain stimulation is approved for adults with movement disorders. Is it FDA approved, or are the implantable devices FDA approved for adults with epilepsy? Because, the whole practicality of arguing with Medicare. Okay.
When is surgery not optional?
Okay.
couple situations. So for this audience, surgery is not an option when the risk of the surgery outweigh the benefits compared to your other therapies, basically, okay? So if I was seeing, your child and I was like, well, they could undergo surgery, but the surgery I'm going to do is going to handicap them, further than they already have with a low chance of seizure reduction, it's not worth it. Like, we can find something better to do. In general, otherwise, in the epilepsy population, surgery is not indicated. Obviously, I would say it's not generally indicated in people who have good seizure control. One can argue that, If you had a person, for example, that has a lesion that's causing their seizures in their own medicine and they're seizure-free, based on that definition, you could say, well, they shouldn't have surgery because they're seizure-free. But on the flip side, if you could take that lesion out and they don't have to take medicines anymore, I think that would be a reason to consider surgery. Again, that's a risk-benefit comparison. And then there are epilepsy syndromes that we know are age-limited epilepsy syndromes that start at a certain age, they go away at a certain age. Those people are not candidates for epilepsy surgery. We need to either wait it out, or most of them can be controlled with meds, honestly, so we don't have to worry. So those are the people who are generally definitely not candidates.
Otherwise, everybody with drug-resistant epilepsy should be evaluated for, are you a
Right.
candidate for
That's
epilepsy surgery? And the evaluation process itself actually can lead to better outcomes, whether or not you get surgery.
right.
And that's actually been shown in good studies, which is, I'm not trying to sell the surgery, it's actually when you get the team-based care, you actually get to evaluate the seizures and everything else going on all together, and you can be connected to resources that can be helpful for other comorbidities, or actually figure out what's going on with the seizures.
Yep. That,
Whether or not you get surgery, it's
yeah, that point's an important one because to me, like she said, when you failed 2 drugs, you deserve the opportunity to discuss epilepsy surgery. So if the conversation is you're not a candidate, that's when I would say back to that provider, explain to me, like I'm in the 5th grade, why I'm not a candidate for epilepsy surgery. Because if you haven't done the evaluation, how is it that you know I'm not a candidate for epilepsy surgery? And then the other thing I tell people to remember is undergoing a phase 1 evaluation does not mean undergoing surgery. So doing the evaluation is just trying to find out, are you a candidate? So a lot of people, they don't even want to start the process. They're like, I'm not doing surgery. I was like, do the evaluation. That's not the surgery. We will have another conversation before the surgery happens. See what your option is.
And now there are so many more options than before. So 20
Yep.
years ago, there was really only one option, right, resection. And then now there's so many more tools and so many more technologies. So there really is a lot of hope. And then actually going back to learning together across the country, we're for learning when is it worth it to you? What does worth it mean, right? It doesn't necessarily mean the seizure count and everything, or medications. It's the other things that Dr. Perry talked about, right? The quality of life, behavior, communication. So we're all doing research and learning about that together to learn about outcomes that matter to you with your lived experience.
I do have time because my plane has been delayed.
So going back to the question around age, and one of the concerns that was brought up by our neurology team was when asking questions around RNS and VNS was her age, as well as she has small head syndrome. Is there any sort of concerns that need to be considered for the, small head syndrome, so on and so forth?
No. There are some, in the very young, Sandy, pipe in if you have, we usually say under 2, like the skull is thinner. So for a thing like an RNS, we don't have as much room to work with because the skull's not thick enough yet to implant. So there are some limitations from head size, but as she said, brain has done and so most surgery based on age is really just, again, it's risk and benefits, but it depends on what the surgery is, what are the risk of bleeding, do they have the body volume for that, those kinds of things. But yeah, the device could feasibly be done sooner. Of the team, yeah, for sure. For sure. If you're not doing a lot of surgeries in that age group, then you're obviously going to have a different comfort level doing that, yeah. I don't think you can say it that way, because there's not a direct comparison to put them together. I would say I believe in my answer that theoretically, to me, going to the thalamus, which is in the network, might be a more direct thing, but I don't think we know that yet. So I think the VNS is still fair game, and it's certainly not. It's a different procedure, right? So again, that's comparing the risk and the benefits of that procedure versus your other and what we know about seizure reduction to decide which one really is best. And it doesn't have to be the only one. You could have both. So. There is only there are consortium of various things in the adult world that might be on specific subject matter. There is not, that I'm aware of, an adult organization like PERC yet, but there certainly are people who want to replicate that.
Do you have a transition special interest group?
So there are people who are interested in transition. We have almost a special interest group for everything, There's people out there that are, we have 14 on the website right now, but it's, a person gets an interest in something, and then they find that there are other people at other places that are interested in it, and they form these groups, and then they start doing their thing. Okay, we got 2 more questions.
Do you recommend corpus callosotomies not for injury drop attacks? Are you recommending that, and why?
Yeah, I recommend callosotomy a lot. So if you have generalized epilepsy, so tonic seizures, tonic-clonic seizures, atonic seizures, atypical absent seizures can all respond to callosotomies. So it's really more of seizure type and EEG pattern. If you had those seizure types and on the EEG pattern it's clearly focal, then obviously I wouldn't do a callosotomy. I'd go after the focus. But if it looks like it's a generalized issue, whether you fall or not is a bit irrelevant. That's originally what people think of, because callosotomies were always done to, reduce injury from falls, but that doesn't have to be the only reason to do the procedure.
I got that answer a bit, but everywhere you look, it's drop attacks.
Yeah, it is. Yes. And I said, I think we're using it a lot more now that we have techniques that are a little less invasive. It's a whole different discussion to have with a person when it's a less invasive procedure.
In the opening session, Tracy mentioned the research database that the LGS consortium is working on, that we can opt into as families. Does that data flow into this?
So into the PERC stuff, no, not yet, but we are working. It's useful that I'm the president of PERC and that I'm also on the board of LGS, because I can help make things like that happen. What we would like to see in PERC is that PERC was really built off of the Children's Oncology Group model. So in the United States, if your child has cancer and you go to a hospital, that hospital is most of them are part of the Children's Oncology Group, and they go into a protocol for X cancer that they have. It's all research. Every patient is research. What we would want to see is one day you walk in to any hospital in PERC and you have LGS, they open up the LGS template, your note will be written according to that template so that we're all collecting the same things. We have a standard procedure by which every X number of years you get, neuropsych testing, every X number of years you have an MRI maybe, whatever. And it's being done that way everywhere. We collect natural histories and understand the course of disease. We can understand different ways to treat, because we all do things slightly differently. If we don't have well-established ways to do it, we take the tools we have and we use them. So we don't need a study to compare, because by nature, we're doing things differently. So if we're collecting the same information and we're just taking a different path, then we can start to directly compare my path to your path, and let's see which one's better. And then start to hone in on what is the way to do that. So the LGS group in PERC is getting ready to do a Delphi process, which is basically a consensus process to kind of determine what we consider to be the standard of care and things that should be done in LGS. We're then going to use that model to apply to our clinics. So at Cook, for instance, we have a grant to start a LGS clinic where we will have neurology, neurosurgery, psychiatry, psychology, developmental pediatrics, all in part of that network, and we will do the things we need to do. And hopefully we'll start to see that at other centers, and we're all collecting the same info, and then very quickly we can start to put these stories together. And with families doing what you all are doing, that has occurred because centers weren't doing it themselves, right? And families were like, tired of waiting, so we're just going to do it for you. That's what a lot of rare diseases have done. They're like, just give me the records and we'll figure it out.
Our database will be a complement,
Correct, for sure.
and you don't have to be at one of those 28 sites.
Correct, yep.
A worldwide database.
All right. Yeah. Well, compared to the callosotomy, I mean, they're definitely different. From a risk of procedure standpoint, I mean, it's neurosurgery. There's risk of infection. There's risk of bleeding. It's pretty low with both, frankly. It depends on the method at which you do it, but low with both. Sometimes when you do thalamic stimulation, you can have, some complications with abnormal movement or sensory changes or things like that, because that's part of what the thalamus does. But you can correct that by changing the stimulus parameters. I don't know, any other big differences you would say between the two?
For any implant, it doesn't naturally belong there, right? So there's a chance of infection. And then for movement disorders or epilepsy, actually, when you look at the trials, the complication rate in terms of having wound issues or healing issues or implant infection issues is up to a third, right? Like in the adult DBS trial for epilepsy, about 1 in 3. Right, so the wound healing issues, because it's covering up something that you've put in that doesn't belong in the body, those issues can be challenging. So are they catastrophic, right? Are they bleeding in the brain? No, but are they things that may set you up for needing further surgeries in the future? Yes. So I think just recognizing it doesn't belong in the body and that there may be challenges with dealing with implant-related issues is important.
Not everybody that has a callosotomy has that experience. And I wish we could explain to you who does and who doesn't. I wish we could explain to you who's going to do really well and who's not going to do really well. Again, another project of this group is we're looking at the connectivity of the callosum and post-imaging to try to figure out, is there a connectivity or an EEG connectivity pattern that tells us the people that are going to do really well or have problems? And we don't know. I can't predict it for you. I can only tell you it happens in some people. The IQ level after of a callosotomy? Or No. IQ should not be taken into consideration of whether surgery occurs. That would be something that in the past people have taken into consideration, feel like people who have low IQ or low functioning are not candidates, and they do not do any poor, if that's what you mean.
I heard the opposite.
Really?
So, yeah, it was a discussion of, I don't want to say more to lose, but.
Yeah. Oh, that is true. Indeed, right? People who have lower IQs are people who you're going to see potentially bigger changes in them if they do well after surgery, right? right? Because they're not having seizures anymore, so they've got a lot of room to run. Whereas if you're a person who's already very high functioning, you've got a bigger chance that we might do something to lower that. That is true, but I don't think it. Yeah, sure. It's much more. The thing about disconnection syndrome, right, is a lot of the things about disconnection syndrome take a really good neurological examination to understand left, right, visual fields, the ability to put it together. We can't do that in the overwhelming majority of people that have callosotomies. So yeah, I'm not doing callosotomies in like high IQ, healthy people, but they're also not generally having tonic and atonic seizures. That's not the population of people that have that.
I mean, I'm
But,
sure
yeah.
that's the whole
Yeah,
discussion
sure.
for my, they asked
Yeah.
for his neuropsych exams.
Yeah, and they should. That's
made
what.
it like it was not a huge part, but a part of
Yeah, it's definitely something to consider. So when I'm talking about a callosotomy, again, like I said earlier, in a kid who walks independently, maybe runs, that takes a lot of coordination. A person who can carry on some amount of conversation. I do talk about those risks and say it's much more likely you're going to experience that as opposed to the child who does not do those things. Like we won't know, right, that it changed anything from that aspect for them. So they're definitely better off from a seizure standpoint. You have to really think about the potential risk because it carries a little more weight for you. Yeah.
How would you quantify the risk of ongoing seizures
Yeah.
every year, right?
Right.
That is going to actually
Correct.
hit your neurocognitive
Yeah. No.
and then also the risk of death
Right.
every year of living with.
Right. Those are the things you have to compare to it again. But I think my point is all of those things come up. That comes up in the discussion. We do have some other ways where we may be able to address it without. So we might say, okay, when we talk about all this, callosotomy we think it's going to work and it will work quickly, but so might RNS and it doesn't carry with it those other things. So that's going to be the treatment I prefer. Again, that's a team discussion to figure out what makes the most sense for you. As far as like,
Higher risk or more likely candidate, is it younger, better?
well, it tends to be younger people tend to get them. They're not doing a ton of them in the adult world, though they should. There's no reason, again, that they wouldn't benefit from them. And there's several studies in adults that show that. Maybe a little more risk in the adult population. Their adverse effects are a little bit higher than some of the pediatric studies I've seen, but I wouldn't say a lot higher. Obviously, the sooner you do it, the better. The earlier you do epilepsy surgery, the earlier or the more likely you are to achieve more favorable outcomes.
There was one treatment on the horizon. Are there other treatments on the horizon that there's to look out for in the next 3-5 years, however long?
There's always stuff being developed. I think what's most on the horizon is better understanding of what we've got. Okay, because we've got these new devices that we're pushing further. Anytime we get new devices, we know what it's indicated for, and then we start to use it for other stuff. And a lot of times, the first papers you read about other stuff are encouraging, but you're like, yeah, it's not great. Well, you have to take in consideration we're pushing the envelope pretty far. So you take those results with a grain of salt because you start to refine what they're good for, and it gets better and better and better in those things. So I think mostly what you're going to see is that getting better. I think you're going to see maybe some devices trying to get towards smaller or batteries that recharge themselves, and those kinds of things that make it easier to use. Those are probably the biggest things you'll see in the near term, if I had to guess. So I'll take one more question because then I do actually have to go to the airport.
Does any of the stimulate through any of the RNS, the VNS, does stimulating the brain affect your cognitive function at all, like during the stimulation or anything?
So during the stimulation is so short that I'm not really sure there's any measurements of that to my knowledge. But there are studies of like neuropsych and cognition, quality of life, those kinds of things in these trials, and there are improvements. There are some higher rates too, right? And wasn't there a higher rate of depression or something in the Sante trial? I feel like there was. It wasn't a huge number, but it was more than the non-stimulated group. So, I mean, there's potential adverse kind of non-seizure things that could occur as well. Okay, fantastic. This is a great session. Quite interactive. Appreciate everybody's time. Appreciate you coming.